So today I would like to talk about volume and pressure ventilation in neonates, of course. Hopefully it's gonna work. Okay. So I would like to talk briefly about the basics. Why do we ventilate babies? What are the basics of ventilation? Then I would like to talk about, of course, volume and pressure ventilation, and just talk about our guidelines, how we should set up our ventilators when we have a baby on our unit. So what are we aiming for when we are providing respiratory support to our babies? Of course, we would like to maintain adequate gas exchange, but at the same time, we would like to minimize risk of lung injury, which is called ventilator-induced lung injury. We need to minimize hemodynamic impairment, and of course, to avoid injury to other organs like our brain, eyes, kidneys, and gut, and reduce work of breathing. When we decide to initiate or escalate ventilatory support, we should always take into account the risk of ventilator-induced lung injury and the systemic effects of poorly controlled ventilation, like we can damage the brain, the eyes, the kidneys, and the gut. And just briefly, the basics, I'm sure you know that. So when we talk about oxygenation, so our oxygenation is dependent on mean airway pressure. There's a small picture that you can see what mean airway pressure means exactly. And when we would like to improve our oxygenation, we would like to increase the mean airway pressure. So we should increase our PIP, so peak inspiratory pressure, the PEEP, the positive and expiratory pressure, and the inspiratory time. The other part is the CO2 clearance or ventilation. The CO2 clearance is dependent on alveolar ventilation, which is proportional to our tidal volume and of course the minute volume. So the minute volume is going to be our tidal volume times our ventilator or respiratory rate. We can increase the tidal volume increasing by our PIP, so the peak inspiratory pressure, decreasing the positive and expiratory pressure. So we are going to have a bigger gap between the maximum pressure and the minimum pressure, and increase our tidal or inspiratory time. And when we would like to increase our minute volume as well, we can increase the ventilatory rate. Now, when we talk about mechanical ventilation, or when we ventilate a baby, we always use patient-triggered ventilation. So our machine, either the Stephanie or the Sophie, is going to detect our patient's inspiratory flow, and it's going to trigger a positive pressure breath. So because of this, we need a critical trigger level, our trigger threshold, and it must be reached in order for each positive pressure breath to be delivered. The size of breath is going to be our tidal volume, as you know. So now our main topic comes here about pressure limited ventilation and volume targeted or volume guaranteed ventilation. When we talk about pressure limited ventilation, our PIP, so our peak inspiratory pressure, is going to be constant. So we are going to set a pressure, and it's going to be reached with each breath, and our tidal volume will vary from breath to breath, and it is going to depend on the compliance and the resistance of the lung, and of course on the ETT leak. there is an obvious risk of lung injury because we can either hyperinflate the lung or we can cause atelectasis if our set pressure is not going to deliver ideal tidal volumes. So there is a picture. So on the bottom, you can see the pressure control. So you set an inspiratory pressure, and depending on the lung compliance and resistance, it's gonna deliver variable tidal volumes. And when we would like to deliver volume targeted, sorry, or volume guaranteed ventilation, we are gonna set a maximum PIP and the desired tidal volume, and our working PIP is going to be automatically adjusted. And once our target volume is reached, the ventilator cuts the inspiration short. So ideally, this volume targeted ventilation delivers a consistent tidal volume, even with varying patient effort or variable lung mechanical characteristics like the compliance and the resistance. So on the top, you can see that we are going to set a tidal volume, and depending on the lung mechanics and also the ETT leak, our machine is going to adjust the working PIP that the baby needs. So there are numerous advantages of volume targeted ventilation. The main thing is going to reduce the variability of the tidal volume. And with this, we can avoid delivering too high tidal volumes, so we can reduce voyeur trauma. We can also avoid very low tidal volumes, and therefore we can reduce the risk of atelectal trauma and hypercarbia. And we can decrease our tidal volume fluctuations as well. So we can have more stable CO2s. We can reduce the fluctuations in cerebral blood flow, which is dependent on PCO2, and therefore we can decrease the risk of brain injury. The other important thing when we set a ventilator is going to be the frequency, not the respiratory rate, but the type of ventilation that we are going to use. The two main groups are the SIMV ventilation and the assist control ventilation. Sorry, so the SIMV ventilation, it stands for synchronized intermittent mandatory ventilation. So in SIMV, we need to set a number of positive pressure breath, and any spontaneous breath above the set rate, they won't be ventilator assisted. While on assist control that you usually see on the unit, using assist control, each patient trigger breath is gonna be supported by the ventilator, and using this mode, so assist control along with volume guarantee, is going to be associated with more stable tidal volume, and therefore we can reach a better oxygenation and reduce tachypnea rates compared with synchronized intermittent mandatory ventilation, so compared to SIMV. Sometimes you can see on on the screen of the machines that there are different loops set. Maybe the most important loop is the pressure volume loop, the PV loop, which is going to show you the dynamic compliance of the lung. So it's going to show you the change in volume for a given change in pressure. So you can see an example for a PV loop. You can see the inspiration and the expiration. And if there is any change in your compliance, for example, the compliance is getting worse and worse, you are going to need higher pressure in order to deliver the same amount of volume. So your loop, the shape of your loop and your loop is going to change. And of course, you can see signs of hyperinflation or over distension of the lung. And the other important loop is the flow volume loop, which gonna show you the resistance of your airway or of your lung. Sorry. Okay. Sorry. Okay, so I think you know, and you can see that especially for extreme preterm babies who need ventilation, we always need to use assist control volume targeted or volume guaranteed ventilation, because now clinical trials suggest and have suggested that with volume targeted ventilation we can provide an effective gas exchange even with lower pressures. So we can avoid hypocarbia, we can avoid excessive tidal volumes and pneumothorax. Having a more stable CO2, we can avoid severe IVH, decrease the ventilator days, decrease the chance of developing bronchopulmonary dysplasia or chronic lung diseases, and reduce the mortality in small babies. Okay, so in a unit we have two different machines. One is the Sophie ventilator, which you usually can see and use, and the other one is Stephanie. So this is from our guideline how we should set our ventilators. This is mainly for initial settings. So we mainly use assist control, but also we can use SIMV, for example, for HI babies who are big term babies who tend to be tachypnic because they want to compensate their metabolic acidosis, and we would like to avoid hypocarbia because it's gonna worse or it's gonna affect the brain injury. So we don't want to support each breath. So SNV can be beneficial for those babies, but for extreme preterm babies, as I said before, assist control mode is more beneficial. I think sometimes it's a bit confusing, and it's good to know that when we use Sophie ventilators, we are going to select either assist control or SIMV, and then if we would like to use volume guaranteed ventilation, we need to set a tidal volume limit, but it's going to be our tidal volume target, so we would like to guarantee to deliver these tidal volumes. And when you don't set any, it's going to be pressure control ventilation or pressure targeted ventilation. But on the Stephanie, on the bigger machines, when you would like to use volume targeted ventilation, you need to select this weird VCVTEX mode, because there is another mode which is called VT lim, but it's going to be a limit and not a target. So it is confusing, but there is a difference between the two machines. So the suggested starting tidal volume, it should be between 4 and 6, but 5 ml per kilogram is going to be okay in most babies. Extreme preterm, very, very small babies, less than 26 weeks, and babies with chronic lung diseases may need higher tidal volumes, and babies with pulmonary hypoplasia or congenital diaphragmatic hernia, sometimes they need lower tidal volumes to protect their lungs. As you know, we always have to set a maximum pressure, a Pmax, which should ideally be above our working PIP by 20%, because it should be high enough to allow fluctuations around our average or our working PIP. We always have to set our PEEP which is usually between 5 and 6. Of course, we can use higher PEEPs, for example, in pulmonary hemorrhage, or for bigger babies with poor oxygenation, because it's going to increase our mean pressure. We have to set an inspiratory time, which is usually around 0.35 and 0.4. We have a backup rate. And when you need to set a backup rate, you need to titrate between the inspiratory time and expiratory time on SOFI. But you have to keep in or bear in mind, when you use assist control, the backup rate is going to deliver untriggered inflation if the infant's breathing rate falls below this rate. But if the baby's rate, breathing rate, spontaneous breathing rate is above the backup rate, because it's assist control mode, all your breath are going to be supported. So it's mainly important if the baby's rate, spontaneous rate falls below this rate. So this is what our guideline tells us how to set a ventilator initially when you have a new admission to the unit. So thank you.